Good evening friends, welcome to my channel Critical Care Basics. In the last lecture, we were discussing about how to treat acute pancreatitis in ICU. In the last lecture, we covered about the etiology of pancreatitis, the presenting features and the clinical and the investigations that we get done in acute pancreatitis. This part 2 will be focused on how to assess the severity of acute pancreatitis. That is the basic thing required for treatment. So let's start acute pancreatitis part 2. Now this is revised Atlanta classification of acute pancreatitis. Acute pancreatitis Atlanta classification was made in 1992, but later it was revised. This helps to assess the severity of acute pancreatitis. There are many caveats in this system. It depends on it takes into account the local determinants like presence or absence of peripancreatic necrosis and inflammation, and necrosis whether it is sterile or infected, and systemic determinants like presence or absence of organ failure. So in this revised Atlanta classification, there are two phases, early phase and the late phase. Early phase covers the first week of acute pancreatitis, and after first week, the rest of the acute pancreatitis is treated or defined as a late presentation or late acute pancreatitis. The severity in the revised Atlanta classification, the severity is distinguished or is divided into three parts: mild, moderate and severe. In mild, there is no organ dysfunction. In moderate, there is organ failure. We'll come to it, what organ failure and how it is classified. But if there is organ failure and it recovers within 48 hours, then that is moderate. And if the organ failure does not recover after 48 hours, then that is severe. There are basically two types of acute pancreatitis: edematous, in which there is no necrosis, and necrotic, when there is evidence of necrosis. So we will go in some detail of this revised Atlanta classification. So Atlanta classification divides acute pancreatitis in two distinct types: interstitial edematous acute pancreatitis and necrotizing acute pancreatitis. The interstitial edematous acute pancreatitis is characterized by acute inflammation of the pancreatic parenchyma and peripancreatic tissue, but without necrosis. As the name suggests, there is only edema but no necrosis. So there is without recognizable tissue necrosis. And as the name suggests, necrotizing acute pancreatitis suggests that there is inflammation associated with pancreatic parenchymal necrosis and or peripancreatic necrosis. So whenever there is necrosis, it is classified as necrotizing acute pancreatitis. So this CT film will give clarity into what we are saying. The contrast enhanced CT criteria: in interstitial edematous pancreatitis, there is pancreatic parenchymal enhancement by intravenous contrast. So you can see the whitish pancreas that is nicely getting enhanced by the contrast, and there is no blackening or black spots which are suggestive of necrosis. While in necrotizing acute pancreatitis, there is lack of pancreatic parenchymal enhancement. You can see that the pancreas is not enhancing, some parts are enhancing, but you can see this black shadow within the pancreas. So this is suggestive of necrosis. So this is necrotizing acute pancreatitis. And as you can see, there is peripancreatic necrosis as well. The blackening black spots around the pancreas suggests peripancreatic necrosis. So this is acute necrotizing pancreatitis and this is acute interstitial edematous pancreatitis. Now fluid collections associated with two different types of pancreatitis are termed differently. For example, in edematous pancreatitis, fluid collections associated with interstitial edematous pancreatitis, if it is less than 4 weeks of duration, it is called as acute peripancreatic fluid collection or APFC. And after 4 weeks, if the inflammatory wall gets organized, then that is called as pancreatic pseudocyst. While fluid collections associated with necrotizing pancreatitis, if the duration is less than 4 weeks, then it is called as acute necrotic collection, ANC. And after 4 weeks, if the wall gets organized, then that is called as wall of necrosis, or WON. We will try to understand briefly what these terminologies mean. First of all, we will see acute peripancreatic fluid collection, APNC. So by definition, this is fluid collection associated with interstitial edematous pancreatitis. There is no associated peripancreatic necrosis and seen within the first 4 weeks, and without features of a pseudocyst. So if there is pseudocyst, there will be a clear-cut wall that will be seen. If that wall is not seen and the duration is less than 4 weeks, then this is called as acute peripancreatic fluid collection. What are the CT criteria? How does it look in CT scan? Homogeneous collection with fluid density. You can see nice fluid density around nicely enhancing edematous pancreas. It is confined by normal peripancreatic facial planes. So you do not see any wall sort of. It is confined by normal peripancreatic planes. No definable wall that we have already seen, and adjacent to pancreas. That is, there is no intrapancreatic collection or extension. Pancreatic pseudocyst. This is an encapsulated collection of the fluid with well-defined inflammatory wall, usually outside the pancreas, with minimal or no necrosis. So again, necrosis is not present, and this is seen more than 4 weeks after the onset of interstitial edematous pancreatitis. You can see nice fluid collection, and you can see it is encapsulated by a inflammatory tissue wall, and you do not see any necrosis. CT criteria, well circumscribed, usually round or oval, homogeneous fluid density, and no non-liquid components. So you do not see tissue in this pseudopancreatic cyst, and you can see a well-defined wall, that is, it is completely encapsulated. So this is after 4 weeks. The third terminology is acute necrotic collection. This is seen in less than 4 weeks in a patient of acute necrotizing pancreatitis. So it contains both fluid and necrosis associated with necrotizing pancreatitis. Necrosis can involve the pancreatic parenchyma and or peripancreatic tissues. So it can involve pancreatic parenchyma, or it could surround the pancreas. See here, there is the pancreas not properly enhancing, whole of the pancreas is not enhancing. You can see a radiolucent or darkish area, that is necrotic area within the pancreas, and occurs only in setting of acute necrotizing pancreatitis. It is heterogeneous and non-liquid density of varying degrees. So you can see varying degrees. Here you can see non-fluid consistency, here you can see fluid consistency, and no definable wall encapsulated. You do not see a wall. It is contained in the normal pancreatic planes, and location is intra or extrapancreatic. Part of it is intrapancreatic, and you can see also some tissue collection outside the pancreas. So this is acute necrotic collection. Lastly, wall of necrosis. This is seen after 4 weeks in a patient of acute necrotizing pancreatitis. So it is mature encapsulated collection of pancreatic or peripancreatic necrosis that has developed a well-defined inflammatory wall. Usually occurs more than 4 weeks after the onset of necrotizing pancreatitis. What are the CT criteria? Homogeneous with liquid and non-liquid density. You can see mostly liquid, but some non-liquid density as well. Well-defined wall, that is, it is completely encapsulated, right? And location is intra and or extrapancreatic. This is in contrast to pseudocyst, which is usually always extrapancreatic, and maturation usually requires 4 weeks after the onset of acute necrotizing pancreatitis. So these are the 4 terminologies: acute collection, acute necrotic collection, then pseudocyst, and walled off necrosis. Then Atlanta classification, as we have already seen briefly before, it divides the patients of acute pancreatitis into 3 degrees depending on the severity. If there is absence of organ failure, that is mild acute pancreatitis. If there is evidence of some organ failure but it gets corrected or gets resolved within 48 hours, then that is moderately severe acute pancreatitis, and if the organ failure persists after 48 weeks of the onset of acute pancreatitis, then that is severe acute pancreatitis. Now, assessing the severity of acute pancreatitis, one is we have already seen how to assess the organ failure, but there are various scoring systems, and we will briefly touch those scoring systems that are still being used. So we will start with the Apache score, or acute physiology and score, Apache 2. This was originally developed for critically ill patients in ICU. This was not developed per se for acute pancreatitis, but it is still used. It uses 12 physiologic measures and extra points based upon the presence of chronic disease. So, most widely studied severity scoring system in acute pancreatitis. So, in acute pancreatitis, it is still most widely used studied scoring system. What are the advantages? It has good negative predictive value and modest positive predictive value for predicting severe acute pancreatitis, and can be performed daily. And decreasing values during the first 48 hours suggest mild attack, while increasing value suggests severe attack. Studies suggest that mortality is less than 4% with score less than 8, and is 11 to 18% with score more than 8. So as soon as the score goes above 8, I have not gone into detail of how to calculate Apache 2 score. There are calculators available online and you can use them. The problem with acute physiology score is it is complex and cumbersome, and it does not differentiate between interstitial and edematous pancreatitis. It also does not differentiate between sterile and infected necrosis. So that is the problem. Secondary has poor predictive value at 24 hours. So that is why Apache score is now less commonly used for predicting the severity of acute pancreatitis. The second was ransom criteria. Now this is also out of vogue, but some medical centers still use ransom criteria. This has different set of criteria, slight different set of criteria for alcoholic pancreatitis and biliary pancreatitis. On admission, each criteria gets 1 point. So on admission, if age is more than 55, you get 1 point. If total WBC count more than 16,000, 1 point. LDH more than 350, 1 point. AST more than 250, 1 point. Sugar more than 200, 1 point. And after 48 hours, drop in hematocrit more than 10%, 1 point. BUN increase more than 5%, 5 milligram, 1 point. Calcium less than 8, PO2 less than 60, and base deficit more than 4, and fluid loss more than 6 liters. So similarly, most of the criteria remain same in biliary pancreatitis, except that the age now becomes 70, TLC becomes more than 18,000, LDH becomes more than 250. Rest of the criteria almost remain the same. If the total score is more than 3, then the mortality is 0 to 3%. If the score is more than 3, the mortality is 11 to 15%. And if the score is more than 6, then the mortality is more 40%. So if the score is more than 6, then the patient is very critical. What are the limitations? Other scoring systems like BISAP are better, can be done after 48 hours. So it takes 48 hours. First you have to assess the patient, and then after 48 hours you have to reassess the patient, and it is not good for young patients. This was basically meant or made for patients who are more than 40 years of age. So this does not do well in young patients. The most commonly used nowadays is modified Marshall scoring system for organ dysfunction. In this, they use 3 different organ systems. As you have already seen in revised Atlanta scoring system, if there is an organ dysfunction, then the patient becomes moderately severe or severe acute pancreatitis. So we have used 3 systems in this. Cardiovascular system, it is measured by blood pressure. Renal system, which is measured by creatinine, and respiratory system, which is measured by PaO2 FiO2 ratio. So if the BP is more than 90 and creatinine is less than 1.4 and PaO2 FiO2 ratio is more than 400, then the score is 0. If the BP is less than 90 but it's fluid responsive, score 1. BP less than 90 but not fluid responsive, then score 2. And BP is less than 90 plus pH is also less than 7.3, that is the patient also has acidosis, then it becomes score 3. And if the BP is less than 90 and pH is less than 7.2, then score 4. Similarly, if creatinine 1.4 to 1.8, score 1, 1.9 to 3.6, score 2, 3.6 to 4.9, score 3, and more than 4.9, score 4. PF ratio 301 to 400, score 1, 201 to 300, score 2, 101 to 200, score 3, and less than 101, score 4. If the patient is not on ventilator, then FiO2 is calculated by this formula. If the patient is on 2 liters per minute oxygen, then FiO2 is considered to be 25. If on 4 liters, 30, 6 to 8 liters, 40, and 9 to 10 liters, 50%. That is, FiO2 will be 0.5. So a score of 2 or more in any organ system indicates organ failure. So 2 points. So for example, fluid is patient has BP less than 90 and is fluid responsive, and the creatinine is 1.6. So patient gets 2 points in any organ system indicates organ failure. Score in patients with CKD depends on the extent of further deterioration. If the patient already has CKD, then the creatinine will change. It will depend on the further deterioration from the baseline creatinine, right? Another system that is simpler to use is defining features of systemic inflammatory response syndrome, or SIRS. 2 or more of the following conditions, if present, indicate severity. Temperature more than 38.3 or less than 36, heart rate more than 90, respiratory rate more than 20 or PaCO2 less than 32, and WBC count of more than 12,000 or less than 4,000. So if any two of these are present, then it's severe pancreatitis. And lastly, the BICEP score. If any criteria more than 3 of any these are present, then it is termed as severe pancreatitis. B stands for BUN. If it is more than 25, you get 1 point. I stands for impaired mental status. S stands for SIRS criteria that we have already seen in the last slide, more than 2 of the 4. A stands for age more than 60, and P stands for pleural effusion. So any 3 of these if present, the patient has severe acute pancreatitis. Now there are also criteria on CT scan, but do we get a CT scan first of all at presentation in patients with acute pancreatitis? So the answer to this question is routine abdominal CT is not recommended at initial patients at the presentation in patients with acute pancreatitis unless there is diagnostic uncertainty. So why? Because there is no evidence that CT improves clinical outcome, and complete extent of pancreatic and peripancreatic necrosis becomes evident only 72 to 96 hours after the initial presentation. So if you get a CT on presentation, it is going to miss all the findings. So ultimately you are forced to do a CT after 72 hours or 96 hours. So it is good practice to do CT after 72 hours unless you are not sure about the diagnosis. So when do we get a CT scan done at presentation? When there is diagnostic uncertainty, or if clinically persistent severe acute pancreatitis after 72 hours of conservative treatment, or patient who demonstrate initial clinical improvement but then manifest acute change in clinical status suggesting that the patient has developed some other problem. So if any of these are present, then you can get a CT scan done immediately. So if you get a CT scan done, then you can calculate CT severity index. So CT severity index is the calculation based on these 2 scores, Balthazar score and necrosis score. Balthazar score gets 1 point for each grade A, B, C, D, E. So as the grades increase, the points increase. For example, if the CT is normal, you get grade A, 0 points. If there is focal or diffuse enlargement of pancreas, then you get 1 point, grade B. If the pancreatic gland abnormalities or there is peripancreatic inflammation, then you get 2 points, grade C. If there is fluid collection in a single location, that is grade D, you get 3 points. And if there are 2 or more fluid collection and or gas bubbles in the adjacent pancreas, gas bubbles usually suggest that there is infection. So if these are present, then you get 4 points. So that is Balthazar score. And necrosis score. As we have seen, how is necrosis seen in CT? A clear-cut, well-defined enhancement of the gland suggests that there is no necrosis. If you are seeing black spots, then there is a necrosis. So if there is no necrosis, 0 points. If 0 to 30% of necrosis, that is less than 30% of pancreas is involved in necrosis, then 2 points. More than 30 to 50%, 4 points, and more than 50%, 6 points. So when you get these points from the Balthazar score and necrosis score, you add them to get a CT severity index. So if the total points are 0 to 1, then the mortality is 0. If total points 2 to 3, mortality 3%. Total point 4 to 6, the mortality is 6%. And if the total points are 7 to 10, the mortality is very high, 17%. So this is also used as a criteria to mark the severity of acute pancreatitis. Lastly, American College of Gastroenterology guidelines. These clinical findings associated with a severe course for the initial risk assessment. So apart from the scoring systems, if clinically you find any of these, then you can have an idea that the patient is landing or already has landed in severe acute pancreatitis. For example, if age is more than 55, patient has a BMI of more than 30, the patient has altered mental status, or there is a comorbid state like diabetes or heart problem. If patient has SIRS, more than 2 criteria, SIRS criteria, we have already discussed this multiple times: heart rate more than 90, RR more than 30 or PCO2 less than 32, temperature more than 38 or less than 36, or WBC more than 12,000 or less than 4,000. Then labs, BUN more than 20, or the BUN is rising in successive tests, or the hematocrit is more than 44, or the hematocrit is rising and elevated creatinine. Radiologically, if you see pleural effusions or pulmonary infiltrates or multiple extensive extrapancreatic collections, so if you see these criteria, any of these, then you can easily diagnose that patient has severe acute pancreatitis. So when do we get this patient admitted in ICU, right? So these are the criteria. All patients with severe acute pancreatitis are admitted in ICU. Apart from that, if the heart rate is less than 40 or more than 150, these are the criteria: systolic BP less than 80 or MAP less than 60, respiratory rate more than 35, serum sodium less than 1. So serum sodium has not come in criteria so far. So if serum sodium is less than 10 or more than 170, patient goes to ICU. If the patient is hypoxemic with PaCO2 less than 50, or the patient is severely acidotic or alkalotic, the patient goes in ICU. If the patient's glucose is elevated more than 800 or serum calcium is elevated, so it could be hypercalcemic pancreatitis, the patient goes in ICU. If the patient is anuric or persistent systemic inflammatory response syndrome, or if the age is more than 60, or elevated HCT, or BUN more than 20, or creatinine more than 1.8, or if the patient is in coma or underlying cardiac, pulmonary disease or obesity. So if any of these are present, then the patient is admitted in ICU. Lastly, we will consider some differential diagnosis of acute pancreatitis, and in next lecture we will talk about how we treat these patients, right? So first of all, ulcers can present as epigastric pain, but then there will be no radiating pain to the back. Amylase and lipase will be less than 3 times upper limit of normal. Gallstones or lithiasis can present as epigastric pain or pain radiating to right hypochondrium. Again, amylase and lipase will be less than 3 times of normal. If perforation is there, peptic perforation can present as severe epigastric pain. There will be guarding or rigidity, which is not usually seen in acute pancreatitis. If there is bowel obstruction, there could be some antecedent cause like history of surgery, colitis or Crohn's disease, and you can see ileus on imaging. I forgot this point. In perforation, you can see free air in abdomen in scout film or in CT. If there is bowel ischemia, in history there could be risk factors for chronic cardiovascular disease or usually the pain is in periumbilical region. Again, amylase and lipase are less than 3 times of normal, and you could usually demonstrate arterial or venous thrombosis or intramural gas or focal lack of bowel wall enhancement. If the patient has hepatitis, again the patient can present as right hypochondriac pain, but the patient has general malaise, jaundice and hepatomegaly. SGOT, SGPT, AST and ALT are usually increased. Lastly, acute abdominal aortic aneurysm. This is a dangerous condition that presents with sudden severe abdominal, back or flank pain and pulsatile abdominal mass. So if the mass is pulsatile, very likely the patient has aortic aneurysm. There would be anemia and lactic acidosis. Aortic aneurysm, extravasation of contrast and indistinct aortic wall could be seen in CT scan. So these are the differential diagnoses of acute pancreatitis. In the next lecture, we will go on to how to manage these patients. We have seen the etiology, we have seen the clinical presentation, we have seen what investigations we have to do. In this second lecture, we have seen how to assess the severity. We have seen the revised Atlanta classification and various terminologies, and lastly various scoring systems to diagnose the severity of acute pancreatitis. Lastly, we have seen the differential diagnosis, and in next lecture we will go on to the treatment. Thanks a lot. If you are liking these lectures, please like, subscribe and share. Bye bye.